Hi, welcome to Pathology Riddles. Today, we are going to deal with this topic called as aneurysm. So under this, we are going to deal with what is aneurysm, what are the types of aneurysm, the risk factors of aneurysm, and a little in detail about abdominal aortic aneurysm, its clinical consequences, and treatment. We are going to go more in detail about aortic dissection in our next video. So let's start with what is aneurysm. The definition of aneurysm is, it is a localized, abnormal dilation of blood vessel or heart. Localized means it is occupying only a small space. It is not present throughout the length of the blood vessel, but it is present only in a small space. It is abnormal. It is dilated. So if you see the diameter of the blood vessel, it is outside of that. So it is dilated. And it can happen in the blood vessel or the heart. So it is a localized abnormal dilation of blood vessel or heart. Aneurysm can be congenital or acquired. Congenital means it is present at birth, while acquired can be acquired anytime after birth. So an example of congenital aneurysm is berry-aneurysm in the cerebral vessels. So basically they are outpouchings or dilation of the arteries, that is the cerebral artery, wherever there is attenuation of the media or weakness of the media. They can also rupture. Well, abdominal aortic aneurysm is mainly because of atherosclerosis. Aneurysms can also be classified as true aneurysms and false aneurysms. What do we mean by true aneurysms? We know that aneurysm is an abnormal dilation of the blood vessel. So in this dilated part, all the three parts of the wall, that is the innermost layer, which is the intima, the middle layer, which is the media, and the outermost layer of the blood vessel, that is adventitia, they are all involved in the dilated part. And in the blood vessel, the part which is usually affected by the myocardial infarction, that is the weakened part or the attenuated part, all the three layers will be involved. So these are true aneurysms. While in false aneurysm, what happens is there is extravascular collection of hematoma, that is collection of blood, which communicates with the intravascular space. So basically there is a wall defect because of which the blood is collected outside the wall, that is outside the adventitial layer, and this is the periarterial connective tissue. So here the blood is connected and that communicates with the intravascular blood. So this is a false aneurysm. It happens outside the wall of the blood vessel. So what are some of the examples of true aneurysm? Aneurysms because of atherosclerosis that happens in abdominal aorta. Then there is aneurysm due to congenital weakness of the vessel. Mainly the media is attenuated at birth, and that's why there are aneurysms. That is also an example of true aneurysm. And then in the heart, after a myocardial infarction of the muscle layer, there will be ventricular aneurysms. There will be ventricular dilation. So all these are true aneurysms. Then what is an example of false aneurysm? It is mainly ventricular rupture, but it is contained by the pericardial adhesion, that is the layer which is formed outside the heart. So this blood accumulates outside the ventricle, but it is contained by the outer layer, that is the pericardial adhesion. And when there are leaks at the junction of vascular graft and natural artery, this is post-surgery when vascular graft and natural artery, when they are connecting at that junction, when there are leaks, the blood will accumulate outside the wall. Here I have also mentioned what is arterial dissection. So we need to know the difference between what is false aneurysm and arterial dissection. In false aneurysm, mainly the blood will be collected outside, while in arterial dissection, usually through a defect in the wall, it will be collected in between the layers of the artery, and then it pushes the layers. Like for example, this is intima and this is media. It is collected between the intima and the media, and then it starts pushing the intima and media. So this is called as arterial dissection. Based on shape, aneurysms are classified as saccular aneurysms and fusiform aneurysm. In saccular aneurysm, there is a discrete outpouching, while in fusiform, it is circumferential. It is present all around the circumference, while here it is only on one side. It is discrete. This can happen anywhere, that is saccular can happen anywhere, but fusiform happens mainly in the aortic arch, abdominal aorta, or iliac arteries. Let's now learn about the pathogenesis of aneurysms. Before that, we need to know about the structure of the artery. As we have all learned that there are three parts of the artery. That is the intima. If you can see the lining over here, mainly the endothelium is present here. This is called as intima. And then we have the media, which consists of predominantly of smooth muscles and some extracellular matrix. And then finally we have the adventitia, which is a loose connective tissue layer. In aneurysm, mainly the structural integrity of the middle layer, that is the media, is affected. And the media mainly consists of smooth muscle cells and the extracellular matrix. And this happens because there is decreased synthesis of either of these, or there is increased destruction of these. So one of the factors that results in aneurysm is inadequate or abnormal connective tissue synthesis. Inadequate or abnormal connective tissue synthesis. Why does this happen? As we all know that transforming growth factor beta, it regulates the smooth muscle cell proliferation and matrix synthesis, which is an important component of the media of the artery. Now, when there is mutations in TGF beta and other downstream signaling pathways, when there are mutation in all these areas, what will happen is there will be defective collagen and elastin synthesis. If collagen and elastin is defective, then the smooth muscle layer connective tissue or the matrix will be abnormal or inadequate, and that will result in weakening of the media of the arterial vessel. Another reason why we have inadequate or abnormal connective tissue synthesis is because of this disease called as Marfan syndrome. So we know that in Marfan syndrome, fibrillin is defective, and fibrillin is the scaffolding protein. Where the media is present, it is the scaffolding protein. If the scaffolding protein is defective, there will be progressive loss of this elastic tissue. And when elastic tissue is lost, there is no strengthening of the media. And because of weakening of the media, that will lead to aneurysm. The third reason for abnormal connective tissue synthesis is mainly in this disease called as type 4 Ehlers-Danlos syndrome, where there is defective type 3 collagen synthesis. And this forms a major part of the extracellular matrix. And if that is abnormal, again the media is weakened, and that leads to aneurysm. We saw that the previous three factors contributed to defective connective tissue synthesis. Now, atherosclerosis is going to contribute to excessive connective tissue degradation. We know that atherosclerosis have got a lot of macrophages, also called as foamy macrophages or LDL containing macrophages. So these macrophages will increase the expression of matrix metalloprotease. That is the proteases or the enzymes that degrade the proteins in the extracellular matrix. So if this increases, then they are going to degrade the extracellular matrix proteins in the media of the artery. Along with that, there is decreased inhibitors of these metalloproteases. Increased expression, decreased inhibition. So they are present for a longer time, and the longer they are present, they will cause increased connective tissue degradation, and that will weaken the media of the artery. The third factor that contributes to the weakening of the media of the artery is loss of smooth muscle cells. As we have seen, smooth muscle cells contribute a major part of the media of the arteries. So this happens primarily in atherosclerosis. So we know atherosclerotic plaque is just below the intima. And because the intima is so thickened, the blood that goes from the lumen to the media has to travel a long way. So the blood supply may be compromised, leading to ischemia of the media of the blood vessel. So as a result, there will be loss of smooth muscle cells, and that can cause weakening of the media of the artery, leading to aneurysm. The second cause is systemic hypertension. In systemic hypertension, the artery or the vasa vasorum that supplies the media of the artery will be narrowed, and this compromises the blood supply to the media, leading to ischemia and loss of smooth muscle cells. So in both cases, that is atherosclerosis and systemic hypertension, there is ischemia. So that will lead to loss of smooth muscle cells of media as well as some degenerative changes. This finally leads to thinning out of the arterial wall, and that is the cause of aneurysm. I hope all these factors and how they cause aneurysm is understood. So we complete the pathogenesis of aneurysm. So what are the predisposing risk factors for aneurysm? As we have already seen, the most common are atherosclerosis and systemic hypertension. Along with that, if there is trauma to the blood vessels, if there is inflammation of the blood vessel called as vasculitis, or if there is congenital defect which causes weakening of the media of the artery, as well as infections. Infections of the artery or infections causing aneurysm is called as mycotic aneurysm. So based on the site that it affects, we have two major types of aneurysms. One is the abdominal aortic aneurysm, other one is thoracic aortic aneurysm. There are some subtypes of abdominal aortic aneurysm, that is inflammatory aneurysm, IgG4 related disease, and mycotic aneurysms. So let's know some salient features of abdominal aortic aneurysm. The most common cause is atherosclerosis. The site where it occurs predominantly in the abdominal aorta and the common iliac arteries, and few cases in the arch of aorta and descending thoracic aorta. It is more common in men, usually after 50 years of age. They can be of saccular or fusiform type. And the size that it affects is mainly 15 to 25 centimeters. So what do you mean by mycotic aneurysms? This occurs when circulating microorganisms infect the thrombus or the aneurysm wall. And once it infects, its suppuration will increase the degradation of media, leading to more thinning, and because of that, there can be rupture of the aneurysm. So where does these infective organisms, where do they come from and how do they reach the aneurysm wall? The source for these could be from infective endocarditis lesion. There can be a septic embolus which reaches the aneurysm wall. Or if there is any suppurative process nearby from the adjacent organs, there can be extension into the aneurysm wall. Or if the circulating microorganism, if it is present in the circulation, it can directly go and infect the aneurysm wall of the artery. Now let's learn what are the clinical consequences of abdominal aortic aneurysm. A simple way of remembering this is by remembering the alphabets that form the vowels in English language. That is A, E, I, O and U. So A stands for abdominal pulsating mass. This aortic aneurysm, which is a pulsating mass, it can simulate tumor. So that is one of the clinical consequences. The second is from the thrombus, that is usually due to atherosclerosis, the thrombus that forms, it can emboli elsewhere. So there can be embolism. And then this large mass, that is the aneurysm, can impinge on adjacent structures like the ureter and the vertebrae, and the patient can present with symptoms because of impingement on those adjacent structures. Or there are vessels which are arising from the abdominal aorta, and these vessels supply the kidney, legs, gastrointestinal system or the spinal cord. And when these vessels are obstructed, they can lead to ischemia of the kidney, legs, GIT or the spinal cord. And finally, there can be rupture of the abdominal aortic aneurysm, and that can lead to massive hemorrhage, and it is a medical emergency. This can occur in peritoneum or the retroperitoneum. So these are the clinical consequences of abdominal aortic aneurysm. It is important to know what is the risk of rupture. So if the abdominal aortic aneurysm is less than 4 cm, it usually never bursts. And if it is 4 to 5 cm, there is a chance of 1% per year that it can burst. And as it grows in size, that is 5 to 6 cm has a chance of bursting as 11%, and greater than 6 cm has a chance of bursting, that is 25% per year. As the chance of rupture for aneurysms which are 5 cm or larger is higher, that's why they require surgical treatment. So surgical treatment can be open placement of tubular prosthetic grafts or endoluminal insertion of stented grafts. So that was about abdominal aortic aneurysm. A small note on thoracic aortic aneurysm. Thoracic aortic aneurysm most commonly occurs due to hypertension, Marfan syndrome, and bicuspid aortic valve. There can be the following signs and symptoms. Because of pressure effect or compression of the airway or esophagus, it can lead to difficulty in breathing or swallowing. Sometimes it can irritate the recurrent laryngeal nerve, resulting in persistent cough. It can also cause erosion of bone, like ribs and the vertebral bodies in the thorax. So that can cause pain in the patient. There can also be cardiac disease due to valvular insufficiency or narrowing of the coronary ostia. And finally, there can be aortic dissection or rupture. So these are the signs and symptoms and complications of thoracic aortic aneurysm. In the next class, we will learn about aortic dissection in detail. I hope you have understood this topic. In case you have any doubts, please write in the comment box. Till then, this is Dr. Susan signing out until we meet in the next video.